Okay, I'm recording. All right. As far as I'm aware. All right. Okay. So these medications are again going to be used for my adrenergic drugs. All right. My autonomic nervous system is divided into the parasympathetic and the sympathetic nervous system, which is what we talked about last week, where the parasympathetic is considered the cholinergic and the sympathetic is considered the adrenergic. All right. So basically, the drugs that we're going to talk about right now are going to stimulate the sympathetic, which is going to be my fight or flight. Okay. So what do these drugs do? Again, they turn on some certain aspects of the fight or flight. Okay. And basically what they do is they make certain things happen that I may want based on what these medications do. All right. So for example, if I wanted to turn on, again, like dilating my airways, right? I could turn that specific one on by targeting the beta receptors in my lungs. Okay. So what neurotransmitters do these ones use? The norepinephrine and the epinephrine. Okay. And sometimes dopamine, but mostly the norepinephrine and the epinephrine. All right. Because those are what's going to simulate my fight or flight. All right. So if I go to the next slide, all right, we talked about what the receptors were already, which are basically, again, those beta and alpha, right? My alpha are in the body and my beta are on the heart and the lungs, okay? So it's important to remember those as we keep going through here. All right. So the drugs, I'm going to skip a couple slides here because they're a little redundant. But basically to start here, when you have your adrenergic drugs, all right, the goal is to stimulate the certain receptors to get certain responses, okay? So if I'm going to stimulate, for instance, the alpha receptors, that would be reflected in things that I would see happening in the peripheral nervous systems. If I were to stimulate the beta receptors, I would see that in the heart or the lungs. So if I'm seeing the certain effects, it depends on what receptors that I'm stimulating. Okay. And again, these medications almost mimic norepinephrine and epinephrine so that we can simulate these just like norepinephrine and epinephrine would in the body normally. Does anybody have any questions about that? Okay. So as we go on, all right, the adrenergic drugs are again stimulating these. All right. So I want to start here. This slide right here is very important because it's going to show you basically, I'm going to go by body system by body system, and we're going to tell you what the drug is actually doing via how it's simulating fight or flight, and then the names of the drugs that you may see. Okay. So for example, we're going to start with the respiratory system. Okay. Does someone have a question? Excuse me? Is everybody good? Did someone have a question? Okay. Sorry, I thought I heard someone talking. All right. So I'm going to start with the respiratory tract. All right. My goal here with the respiratory tract is for bronchodilation. That is going to be the one and really only effect that this is going to do to my lungs. Because again, those beta receptors are in the lungs. And then when I have fight or flight, I want to open up my lungs and my airways so that I can let more air in, right? So when I do that, I'm going to take medications that can stimulate the fight or flight. And in response, I'm going to turn that part of the fight or flight on. Okay. So the medications that would do that, the most common one that we're familiar with is going to be my albuterol. Okay, I know we're all familiar with that one. Maybe you've also heard of terbutaline, but those are probably going to be the most familiar unless you've heard of ephedrine or levoalbuterol. But those ones are probably going to be the ones that you've seen the most common. All right, these again are responsible for opening up the airway for issues like asthma, COPD, bronchitis, where my airway is not opened all the way, and then I can falsely turn that on, stimulating that part of the fight or flight to help with that disease process. All right. When we go to the next one, which would be my topical nasal decongestant, there are nasal decongestants similar to Flonase, not actual Flonase, but that can be constituted as an adrenergic drug because they are stimulating the blood vessels in the nose. Because we learned last week that the adrenergic system or the sympathetic system causes vasoconstriction. Right. So if I have arteries in my nose that are swollen or inflamed from inflammation, let's say from seasonal allergies or something like that, I can go ahead and use a adrenergic nasal decongestant, and that will go ahead and cause vasoconstriction of those blood vessels that are swollen or leaking fluid, things like that, and it'll help reduce the inflammation. All right, or the congestion, which would be caused by the extra fluid that comes to the site during inflammation. All right. So again, in this case, we're stimulating the alpha receptors because it's in the peripheral. It's not in the lungs or the heart. Okay. So the drugs that you would see here would be ephedrine. Probably the other familiar one you're used to seeing is phenylephrine. Otherwise, the other ones probably aren't as familiar, but these again would be topical decongestants, usually nasal type sprays that would help cause the vasoconstriction. So we're turning that part of fight or flight on, just localizing it to the nose to help relieve the symptoms that we're feeling with the inflammation. Okay. Does anybody have any questions about this one? Okay.
Yes, I have a question.
Okay.
We want you to kind of, can you slow down a little bit? They put it in a few times in the chat, but my question was when
Okay.
they're in fight or flight, their nasal will be inflamed. So what are we doing here? I missed it.
So for fight or flight, their nasal passage isn't going to be inflamed. However, when you have nasal inflammation, like through everyday circumstances, whether it be like from like rhinitis, like with a cold, or if you have seasonal allergies, like when you would use Flonase, like those types of reasons. All right. You can the inflammation that's happening in the nose is causing vasodilation, it's causing swelling, it's causing fluid to leak into the area. Okay, so when that's happening, I'm not always able to fix it unless I use a medication that can simulate the aspects of fight or flight just in the vasoconstriction. All right, because again, this isn't actually happening when I'm in fight or flight, but we know that we can turn on aspects of the fight or flight system, which happen every day, all day, to regulate my body. So here I'm turning on the vasoconstriction part, but I'm just localizing it to the nose. Okay, does that help? Did that answer your question?
Yes.
Okay.
Yes.
Okay. So again, these aren't necessarily happening during fight or flight, but again, they are just everyday life circumstances, like the respiratory tract rate. If I have asthma, if I have bronchitis, that's not necessarily a fight or flight thing, but we do use aspects of the sympathetic nervous system all day, every day. So I'm turning on that particular part, which is the bronchodilators, which would help open the airway for these disease process. Okay. Same with the nasal decongestant, right? However, in this case, it's going to do the vasoconstriction in the nose. Okay, so we're turning on aspects in different places with these medications to turn on specific parts of the sympathetic nervous system to help with disease processes. Okay. Does that help? Everybody's with me? Okay. So what I'm gonna do is go to the next one. Okay, if you have a question, let me know. All right. So the ophthalmologic or ophthalmic, I'm sorry, I'm bad at pronouncing that. That is gonna be my eyes. All right. All day, every day, my pupils dilate and constrict depending on what kind of light I have, correct? Right. So here with my sympathetic nervous system, I want to turn on the ability for my eyes to dilate. Okay. So in this case, when I would want my eyes to dilate, when I want to turn that on, when it's not usually on or not on all the time, would be for issues like glaucoma. All right, because these medications, if you open up the pupil of the eye, it can put less pressure on the muscles that are causing tension in the eye relating to the buildup of fluid. Okay. Does that make sense? So I would want prolonged, or I would want to initiate pupil dilation to help relieve some of the disease process factors that are relating to glaucoma. Does that make sense?
So you say you wanted to turn it on to related glaucoma or not related?
I want to turn it on to treat the pathophysiology of what's happening with glaucoma. So glaucoma is increased intraocular pressure. So the eye is having a lot of pressure in it from a lot of fluid. Usually the iris muscle in around the pupil is blocking the fluid from draining out of the eye. Which you're going to learn in advanced med surge if you haven't already. And because of that, if I dilate the pupil muscle around the iris, it can help relieve some of that pressure and kind of open up that drainage way so the fluid can actually drain out. Okay, so it's actually by dilating, I'm helping. Okay. In these kind of eye drops, there's a lot of different names, but again, they kind of look similar to the ones that we've seen. You can straight up just have an eye drop called epinephrine. Again, we have the phenylephrine or the tetrahydrozoline. Okay. Questions about the eye? Make sense? Okay. The next one that we're going to do is overactive bladder. So if I have overactive bladder, I am urinating way too much, right? Urine's leaking out. Okay. It's true. So again, in order to fix this, if you remember what happened with the urinary tract during the sympathetic nervous system, like what it did with the urinary tract, right? It expanded the bladder wall so that we could have more urine fill the bladder. And then it constricted that internal sphincter that is not under our control so that the urine wouldn't leak out, right? Because if I'm running or fighting, I don't want to pee my pants, okay? I want to have that bladder fill so that the urine can build up in there. And then I want to constrict the internal sphincter so nothing leaks out, right? That was the sympathetic nervous system's effect on the bladder, right? So if I turn that on here, and I can use that to treat overactive bladder, right? Because if I constrict that internal sphincter, can as much urine leak out? No, right? If I relax the bladder wall, more urine has the opportunity to fill the bladder before I actually start leaking urine out. Okay. So these two different aspects of the sympathetic nervous system, if I actually turn them on, are going to help with what is actually happening with overactive bladder. And the medication that is most common for an adrenergic is going to be mirbetriq, which probably sounds familiar. Make sense? Does anybody have any questions about how this is going to treat overactive bladder? Again, we're turning on what the autonomic nervous system does for the bladder, and that is going to help with the disease process of the overactive bladder issues. Okay. All right. Yes. Yes. Is there a question? Oh, sorry, you were on
Okay,
mute.
can you hear me?
Yes, yes.
Okay, so we're gonna treat them with this medication here,
Mhm.
which extends the wall so it can hold more urine, but it constricts the sphincter so it won't leak out.
Correct. It's doing both.
All right.
Right? And that'll help with overactive bladder. Okay. Questions about this? Okay. I don't know what happened to my camera, but can you guys see the PowerPoint on the screen? Okay, that's all I need. All right. So for the cardiovascular system, all right, what we're having here is we're going to initiate the part of fight or flight that is going to cause vasoconstriction. Okay, and this is going to happen in my beta receptors on the heart. All right, or through the receptors that are on the blood vessels, which would be the alpha receptors, right? Because all my blood vessels are in the peripheral, okay? And there are muscles on there, so I can control those through the sympathetic alpha receptors, okay? Does this make sense? So I'm either targeting the heart itself or I'm targeting the blood vessels, depending on what I want to work on to cause this vasoconstriction, okay? Questions about that? Okay, so for
Can you explain that a little bit more?
yes, so when you have the fight or flight, right? The sympathetic nervous system, it's going to affect the blood vessels by the muscles that are on the blood vessels. It's going to stimulate them to constrict nice and tight, okay? Because again, that's going to increase the blood flow and raise my blood pressure if I'm running and fighting, right? Because I want that blood flow to go around my body, okay? However, those are going to be my alpha receptors because they're on the blood vessels, which are in the peripheral. Does that make sense? Right. So if I'm going to target the receptors, they're going to be the ones that are going to be on the peripheral, which are going to actually affect the blood vessels themselves. All right. But then I can also target my heart itself that can affect blood pressure with the beta receptor that is on the heart. Okay. So I can either affect the cardiovascular system by affecting the blood vessels or by affecting the heart itself, depending on which receptors I want to stimulate. Okay. Does that make sense? I know it's a lot, but to kind of put it into application terms, if I give you dopamine, or no, sorry, not dopamine, if I give you Midodrine, we've heard of this medication, right? So we use this to boost someone's blood pressure. All right. So the way that it does that is it's going to stimulate the receptors that are on the blood vessels. And it's going to say, okay, I'm going to have you turn on and I'm going to cause you to constrict nice and tight. All right. Which is going to raise the blood pressure for the whole body. Okay. Does that make sense? Maybe, kind of, sort of.
Yeah.
Okay, okay. So we're just gonna stay there. All right. I know there's more on this little blip it here, but I'm just gonna say that it's gonna work on the blood vessel Okay, it's going to cause vasoconstriction, which is a part of the sympathetic nervous system that we're going to turn on. Okay, and that therefore is going to raise my blood pressure. Okay, simple enough if I leave it there. All right, we are just going to have these medications be like midodrine, dobutamine, straight up epinephrine. All right, norepinephrine, or again, that phenylephrine. You can see some of these names being used multiple times. Okay, simple enough. Understand how that affects the blood pressure? Okay. So for the next round of information here, we're done going over the specific medications and body systems and what it's doing. All right, so everything that we just went over were indications, why we're using it, or different versions of why we're using it, how it's working, which is the mechanism of action, and then the name of the medications. I just broke them up by body system, okay, and usage. Does that make sense? So for all of those ones that we just talked about, I'm going to go over the contraindications, interactions, and adverse effects for all of those. I just kind of lump them all together as adrenergic drugs, okay? Does that make sense? Okay. So the contraindications or reasons why you shouldn't take these or use these with severe caution would be if you have an allergy, all right, or if you have severe hypertension. Because if you have severe hypertension, a lot of these drugs can cause vasoconstriction, even if that's not why we're giving them. And again, if I already have hypertension issues, it would be damaging to my patient to give them more hypertension. Okay, which could cause things like stroke, MI, PE, all right, other cardiac issues like heart failure. Okay, so I don't want to add more hypertension on top of hypertension. Okay, make sense? All right, because like I said, even if I'm not taking these medications for the cardiac system, it can still cause vasoconstriction as an adverse effect. Okay. So for the interactions, there are a lot. If I showed you the list, it would overwhelm you. So basically, I just kind of picked out some of the biggest ones. And the best thing I can say is to just do a med rec when you have your adrenergic medications, like you recognize that they're taking one. Just compare it to the other medications that they're taking, just to make sure that you didn't miss anything, because to have you memorize it would be insane, and I'm not going to do that to you. Okay. So just know that there's a lot to do a med rec, and I just want you to know the two biggest examples right here, which would be for the adrenergic drugs, just as a whole. So it could be any of the ones that we just listed. If you take that with an anesthetic drug, so like something that's going to put you to sleep, right? That is going to have a risk of causing a cardiac dysrhythmia. Okay. Or if you combine any of these drugs with the MAOI, you have the risk of having a life-threatening hypertensive crisis. Okay, and if I don't know if you remember from Farm 1, the MAOIs have hypertensive issues to start with, and we know that these can accidentally cause vasoconstriction, right? So you kind of have double hypertensive things happening at the same time. Okay, does that make sense? Sure. Okay. For my adverse effects, all right, I kind of have these broken up by body system just to keep them more organized. So for my CNS systems, I'm gonna have mild tremors to seizures. So that can be something that I may see happen to my patient that I don't want. Also headache, nervousness, kind of like anxiety, or dizziness, okay? If with my cardiac system, again, with the sympathetic nervous system, I get tachycardia risk, and I get vasoconstriction. That happens because of the sympathetic nervous system. So even though I'm not meaning to turn these ones on, they could still turn on. Other things can turn on when they're not supposed to. All right, so that could be the vasoconstriction causing hypertension. Okay, that can make the heart beat too fast, causing tachycardia, or it can make it beat way too fast where I get like a AFib or an SVT, or like a VTAC or a VFib type of dysrhythmia, which would be a too fast dysrhythmia. Make sense? Okay. It also can cause nausea and vomiting, muscle cramps, nervousness again, and insomnia. Okay. Questions about this slide before I move on? Okay. So just some nursing implications here. All right, so what I'm looking at is going to be things like you need to assess for asthma, you need to assess for hypertension issues, cardiac dysrhythmias, or other cardiac diseases before you give any of these medications, because again, the risk of having tachycardia, dysrhythmias, or hypertension is a high risk, even if that's not why I'm taking the medication. Okay, as it happening as an invertent effect if I turn things on that shouldn't be on. Okay. Know your patient's baseline, because again, this can affect vital signs. So if I'm going to affect vital signs, I want to know what those vital signs should be for my patient. Okay. Also for IV solutions, these can escalate very quickly. So I want to make sure that I'm being very cautious, because they can, again, put my patient into a dysrhythmia or something like that very quickly. All right. And that, because we know when we give something via IV, it goes a lot faster through the system and it can cause a lot more damage quickly. Okay. If you're using the nasal decongestants, be careful, because you could get rebound nasal decongestion, where the decongestion can also get worse before it gets better. So that is an adverse effect. It's kind of doing like a paradoxical effect, where it's doing the opposite of what it should do. Okay. You're going to want seizure precautions, because that was an adverse effect. So if you know your patient's at risk for seizures, or is showing signs or symptoms, or has had one because of these medications, you definitely want to put them on seizure precautions. Because of the cardiac risk, we're going to want to put them on a telemetry monitor and do frequent EKGs to make sure that they're not having a dysrhythmia. Okay. If you take two adrenergic medications together, the risk of these adverse effects is higher, so your patient needs to be monitored more closely. Okay. Otherwise, this is the adrenergic chapter. Do we have any questions or concerns? I know I'm going a little
So the
fast.
chapters
Yes.
that you skipped over, do we need to know anything on PowerPoint that you went through?
Wait, say that one more time. Sorry.
The PowerPoint slide that we didn't cover,
We
do we
went
need to know anything out of those?
the ones in the beginning.
Yeah.
Yeah, you don't need to know those. It's
You
basically
say
the
we do or we don't?
You don't. It's basically the same information that we did last week, with what receptors they are, what neurotransmitters, what gets turned on and what doesn't. So if you look at the PowerPoint from last week, all of that information still applies. So I just kind of repeated it here. So we don't really need to go over it again.
Okay.
Okay. Any other questions, concerns? Okay. So I'm going to go to the next one, which is 19. All right. Again, I know I'm going a little bit fast, but we lost a good chunk of time with the tech issues. So I just want to make sure that we cover everything. Okay. All right. So these are going to be my adrenergic blocking drugs. So these are going to be ones that sit on the alpha or the beta receptors and turn them. Well, basically they block them so that the body can't turn them on. Do you remember when we talked about that last week? Right. So the medication is literally going to go and sit on those receptors so that the sympathetic nervous system can't actually turn on what they want to turn on. Okay. Does that make sense? Do you remember this?
Are we still in chapter 18?
Now we're on chapter 19.
Your screen not showing 19.
It's not showing 19. It says I'm screen sharing. What does it show on my screen? Chapter 18 still?
Yes, it's still on adrenergic drug.
Okay, hold on one second. Let me see. Okay, can you see it now? Can you guys see chapter 19? Yes, no.
No.
No. Hold on 1 second. Let me try it again. Okay, can you see it now? Better? Okay, I think I fixed it. Okay. So again, these medications are going to block the alpha and the beta receptors. All right, so that the sympathetic nervous system literally can't send a message to them to, again, like dilate the pupils, dilate the airway, the bronchi, to cause tachycardia, to cause vasoconstriction. All of those messages literally won't be sent to the receptors to tell these organs to do things because the medication's literally sitting in front of it and not allowing that nerve signal to get to that area. Okay. Does that make sense how it's blocking it? Any questions about that? Okay. So again, I'm bringing back up this picture. So this is where we're at, the adrenergic blockers. Okay, so again, they're going to turn off aspects of the sympathetic nervous system by literally blocking it so they can't be turned on. Okay. So this is where we're at. Okay. On that little chart. Okay. Again, I'm going to skip through this because it's redundant information that we did last week. Okay. So this is where we're going to start. All right. So this right here are going to be my alpha blockers. We're going to divide these into two. You have alpha blockers and beta blockers. Beta blockers you're probably more familiar with, but the alpha blockers block the actual alpha cells, or sorry, the alpha receptors that are in the peripheral, right? And then the beta receptors are on the heart and lungs. So these ones are going to block more of the peripheral things that the sympathetic nervous system does. Okay, we're good with that? Okay. Let me see. So when you have arterial, because what the sympathetic nervous system does is it causes vasoconstriction, right? So if I have high blood pressure, so hypertension disorders, what I'm going to want to do is literally cause those veins to not be able to constrict. Because if they can't constrict, that can contribute to making my blood pressure higher. Okay. So if I cause them to stay more dilated more of the time versus keeps constricting, right? If I literally stop the epinephrine from the sympathetic nervous system to be able to cause a vasoconstriction in the first place, and that's not going to contribute to raising the blood pressure. Okay, so it's going to keep those blood vessels nice and open longer, which is going to help reduce blood pressure or help prevent the vasoconstriction, which would raise it in the first place. Okay, so if you take an alpha blocker medication for blood pressure, it's pretty effective because it's going to make it so those blood vessels can't vasoconstrict. Okay. We're on the adrenergic drug side. We saw that the medications were trying to cause vasoconstriction, right? To raise the blood pressure, like my midodrine, right? But over here, where I want to turn them off, right, I'm going to prevent them from being able to do that to treat the opposite issue, which is hypertension, right? So they're going to stay dilated and my blood pressure won't raise from any type of vasoconstriction. Okay. Anybody have questions about that? And then the other type of, sorry, does someone have a question?
I got a quick question. So you said the alpha, that blocks the peripheral, and then you said beta blocks, that's the heart and lungs, right?
That's going to be beta, which the beta blockers are going to block the heart and lungs. The alpha is going to block things in the peripheral.
Okay.
Yes, my blood vessels are in the peripheral. All right, they're throughout my whole body. So those would be considered my alpha receptors. Okay. So the other thing that I'm going to
Well, I'm sorry, I got a question.
Yep.
So, beta blockers would like lower the heart rate as to where alpha would like lower the blood pressure.
Yep. Perfect. You're on the right track. Okay. All right. So the only other thing that we really use an alpha blocker for is going to be urinary retention issues, where the other medication, myrbetriq, that we were talking about was going to constrict that sphincter, making it harder for the urine to come out and expand the bladder wall so that more urine could collect, right? If I have issues like urinary retention or BPH, right, where I'm not getting as much urine outflow, the best thing to do for that is to give a medication that's going to turn off or not make the sympathetic nervous system able to constrict that sphincter, right, or relax those bladder walls, right? Because if I can't do that, then basically the more important one is if I can't constrict that sphincter, I'm going to have better urine outflow, right? So I don't even want the body to constrict the sphincter in any way, shape, or form. So if I turn that off, I would be helping with the urinary retention issues. Does that make sense? Okay. So what these medications are doing are, again, they're sitting on the alpha or the beta receptors, depending on which, if it's an alpha blocker or a beta blocker, all right, it's going to sit on its respective receptor and stop the sympathetic nervous system from actually doing its job, right? And so in this case, it's the alpha receptor or the alpha receptors that are being blocked, right? So that those are going to be the ones that are not going to be stimulated by the sympathetic nervous system, okay? So my contraindications here are going to be peripheral vascular disease, any
question.
kind, yes.
So with the SNS system, everything is up. So this alpha blocker is bringing everything back down, just like if it was like a PNS medication.
Similar. So not
Similar.
everything is technically up, but it does stop the body's ability from even making it go up. Does that make sense?
Okay, so everything is still up, but it's just making it. Okay, I get what you're saying.
We're basically preventing it from being able to go up in the first place so that you wouldn't have that issue with this disease process. Does that make sense?
Okay, okay.
That connected a little bit.
I have a question. Okay, so if a patient got urinary retention, you're saying that we give an alpha blocker and that would help them urinate?
Correct. This is going to be like your Flomax.
Oh, okay.
Because it's going to
Thank
stop the ability to obstruct or constrict that internal sphincter anyways. Okay, which obviously you don't want if you can't get a good urine flow. Okay. All right. So again, back to the contraindications. If you have peripheral vascular disease, hepatic, which is liver or renal diseases, coronary artery disease, peptic ulcers, or sepsis, you definitely do not want to take or have a high risk of these medications causing harm to you. If you have sepsis, you're going to get full body inflammation. Okay. And that's going to cause vasodilation in your body. So I don't want to give you a medication that's going to further cause vasodilation and lead to septic shock. Okay. With CAD, again, I don't want to mess with any of the arteries because, again, I could be leading to issues that could loosen plaque or things like that. Liver and kidney disorders, it's just not good. We'll see that with the adverse effects. And then the peripheral vascular disease. I don't want to mess with anything that is going to affect the blood flow with that. Okay. Questions about that? The only interactions right here that I really want you to be concerned about is with Flomax. If you take two alpha blockers together, there's going to be too much of the same thing happening. So you're going to have a risk for hypotension and bleeding. Okay. So if Flomax is one of the ones that you're taking with another alpha blocker, you have a risk of hypotension and risk of bleeding. Okay. That's the only one I want you to know. We good there? So I'm going to show you a list. I'm going to come back to this slide, but if I show you a list of your alpha blockers right here, right? So let's say if I were to take Flomax with Cardura, I would have a higher risk of the patient having hypotension and bleeding, okay, with that interaction. Make sense? Okay. So these are a risk of your most common alpha blockers. The ones that you've seen the most maybe be Prazosin or Minipress, Flomax, and Cardura. All right. So Minipress and Cardura are most likely going to be used to treat hypertension, and then Flomax for the urinary issues. Okay. Those are really the only three I need you to know name-wise. You can be familiar with the other ones, but I'm only going to test you on those three. Okay. When we go to the alpha blockers adverse side effects, all right, again, I broke these into issues, right? Again, it can cause...
Okay, hold on. You go back to medication, you said no, this no.
I'm sorry, the computer broke up. I'm sorry, say it one more time. No. Does someone have a question?
Could you repeat the 3 medications?
The Flomax, so the Flomax or the Tamucilin, the Minipress or the Prazosin, or the Doxazosin or the Cardura. Okay. So those are the 3 I need you to know. All right. And if we go back to the adverse effects, if you have incontinence, all right, that's going to be a side effect, right? Because I'm trying to increase the urinary stream, so I could increase it too much, causing incontinence. Okay. These ones can cause dry mouth, all right, or like nasal, or like throat soreness and things like that. Nausea, vomiting, diarrhea, constipation. So all my GI usual issues. Okay, I'm not super concerned about these unless obviously the diarrhea or the vomiting gets extreme. With the central nervous system, we're hitting dizziness, headache, anxiety, depression, weakness, numbness, and fatigue. Okay. Especially my concern here is with orthostatic hypotension, because if I'm causing vasodilation, we know that vasodilation can cause a drop in BP, which can cause orthostatic hypotension. So my patient needs to be careful when getting up. Okay. Also tachycardia is a risk, edema or swelling, and chest pain. Okay. Otherwise, that is going to be your alpha blockers. Okay. All right. When it comes to my beta blockers, I'm not going to spend a lot of time here because I know you guys already covered beta blockers last semester. But we know that beta blockers are used for angina or chest pain. Okay. Patients who have had an MI, because it can help decrease the heart's like demand in workload, okay, which can give the heart more rest so that it doesn't lead to heart failure. Okay. It can also be used to treat early stage heart failure. And then it can treat dysrhythmias because again, it slows the heart rate down. Migraines, it can treat, but I'm not really focused on that one. And we know it can reduce blood pressure. Okay, so these are my generic uses of beta blockers that can be used for a lot of different things when it comes to the heart. All right, so again, chest pain, MI, early heart failure, dysrhythmia, migraine, and high blood pressure. Okay. Otherwise, those are going to be your big uses. Okay. My mechanism of action here is that it's going to block the beta receptor on the heart. All right. The heart is going to be my goal of the place for it to block. However, it can block the beta receptors on the lungs. So that is a risk factor. So when you see my contraindications, you're going to see severe pulmonary diseases like asthma, COPD, and things like that. Because again, if this blocks the fight or flight's ability to cause bronchodilation, if I'm having an asthma attack or a COPD like exacerbation or something like that, it would cause my airway to be more blocked and exacerbate the effect of the closed airway. Okay, because again, it can block the receptors in the lungs, which is what it would do, which would be to block the bronchodilation, so that it literally couldn't happen if you were having an asthma attack. Okay, so severe. Question?
Yeah, I got a question. I don't even see COPD on there. Is that just like something you telling us, or do we focus on the contraindications that's listed?
So when it says severe pulmonary disease, that would be asthma or
Oh,
COPD.
all of those are under.
Yep, that would be under this umbrella. Okay. And then it can cause bradycardia because we know the goal is to lower the heart rate itself, right? So it can lower it too much. So if you already have low heart rate issues, I definitely don't want to make that worse. Okay. So again, it can be used to treat early heart failure, but once you get to late stage or end stage heart failure, it can make it worse. So we definitely don't want to take it when we get to that stage of heart failure. Okay. And then obviously pregnancy is used with caution. Okay. When it comes to sulfonylureas, those are an oral medication to treat diabetes. So if you take beta blockers with this type of oral diabetic medication, it can increase the risk for hypoglycemic effects. Okay, because we know that sulfonylureas are treating diabetes and they're going to bring down the blood sugar anyways. So this medication can almost enhance the effects of the sulfonylurea, dropping your blood sugar too much. Okay. Let me see. So my adverse effects here are going to be bronchoconstriction because again, it can block the lung beta receptors when either not supposed to, causing bronchoconstriction. Okay, it can cause thrombocytopenia or low platelets. Again, we talked about the bradycardia. It can also depress or slow down the mentation state, which is my depression. It can cause constipation, fatigue. Again, it can make heart failure worse, depending on if you're taking it in late stage heart failure. It can also make it harder to recover from hypoglycemia, which again is why you see the interaction with the sulfonylurea. Okay. You can see how those two both have to do with hypoglycemia and how they can, trigger off each other. And then if you stop taking these suddenly, you could get an MI or hypertension or chest pain. So these need to be tapered off or stopped slowly. Okay. If we go to the medication names, again, these should be very common. They all end in lol. So atenolol, betalol. Yes. Is there a question? No? Okay, sorry. I thought I heard somebody.
Here's a question. Do you want us to focus on all 2, 3, 4, 5, 6, all 6? Or do you have like,
I'm here?
no,
For the
the
drugs.
medical, yeah, which?
I want you to be
Are-
familiar with the names. I'm not going to have you know the information underneath the names. But I do need you to know that any of these medications could be a beta blocker. And it shouldn't be that bad because just recognize the lull. Not good? Yeah,
Well, they all
let me know the
different,
information below.
so.
Yes.
No.
I'm sorry, if you're asking a question, it's broken up. Can you say it again? No? Okay. And then just read through these, but basically know your patient's respiratory and cardiac baseline. All right, because again, these are going to be affected by these drugs. So you want to know where they're at before you give them a medication that can harm them in these ways. All right, be a risk of the the warning of the orthostatic hypotension, teach your patient about fall precautions and taking precautions, and have to move slowly from position to position until they stand up. Again, never stop the meds abruptly. You need to, do it slowly, taper off, because you can go into withdrawal and get cardiac issues. All right, avoid caffeine, and then instruct your patient to avoid alcohol. Okay. Are we good with chapter 19? Okay. Let me see here. All right, let me go to the next chapter, chapter 20. Okay, can everybody see chapter 20 on my screen? I think it just loaded. Okay. So just to remind you, these are some of the things that we're turning on and off. Okay, so if you want to review those pictures I put there again for you. Okay, this is all again redundant information when we talk about the cholinergic system. This is now on the parasympathetic nervous system. We just finished the sympathetic. All right, we're using acetylcholine as our neurotransmitter instead of epinephrine and norepinephrine. And then we're using the nicotinic and the muscarinic receptors versus the alpha and the beta. Okay. So again, just listing this for you. If you want to review through that, it is there for you. Okay. So now all of these drugs, the cholinergic drugs, are going to be used to turn on certain aspects of the parasympathetic nervous system or my rest and digest, okay? Because again, turning some of these on or enhancing the amount that they're on will help certain disease processes. So the way that I have these ones listed is going to go drug by drug, and I'm going to tell you why we're taking it and how it's going to work, all right? Everybody with me? Okay. So what we see here, all right, is the first drug is going to be, the most common name that you're going to see is going to be pilocarpine, all right, or carbachol. I think that's how you say that. This is going to be for glaucoma. Okay, so we saw glaucoma being used on the other end for the sympathetic to help, but we also have medications for glaucoma by turning aspects on of the parasympathetic. There's a lot of different ways you can treat glaucoma. So enhancing different aspects of either one in certain patients can help. So I know it can be kind of confusing that we're treating similar disorders with adrenergic and cholinergic, but different mechanisms of action could help different patients depending on, what issues are going on with their glaucoma. Okay. So here it's actually going to make the pupils constrict. So if I have those pupils causing the muscles on there blocking the passageway for the fluid to drain out of the eye, if I constrict the pupil muscles, I may also be making that pathway larger by making the part of the muscle that's sticking out reduce in size, which makes more room for the fluid to go through. All right, I'm not super concerned about these mechanisms of action because we will do the eye drugs, I think, next week. So we'll go into more in depth about it then, but just know that it helps reduce intraocular pressure by causing the pupil to constrict. Simple enough? Okay, you don't need to know why yet or how that affects glaucoma. We'll do that next week. So you will see pilocarpine again next week, okay? The next medication, yes.
Can you repeat what you just said? Sorry.
Can I repeat
You
what?
said they, did she say it opened up? And then she said it constricted.
By constricting the pupil, which again is, you know, the dark part of your eye, right? If I constrict that, it's going to open up the passageway that the fluid has to drain out of the eye because sometimes the muscle sticks out. So if I constrict it, I'm making it smaller, right? And not so flabby and in the way, and I'm gonna open up the passageway for the fluid to drain out. That make sense? If it doesn't, again, that's okay, because I know I don't have an eye diagram in front of me. You don't even know if you've gone over glaucoma yet. You probably haven't, which is fine. But again, I'm gonna go over that more when we do the glaucoma chapter, okay? All I need you to know right now is that it causes vasoconstriction, or not, sorry, constriction of the pupils, which reduces intraocular pressure, okay? All right. The next medication is called bethanechol. I think that's how you say that. So basically this one is going to treat my bladder issues, okay? So it's going to, the parasympathetic nervous system opens that internal sphincter so that urine can come out, right? And it constricts the bladder walls to kind of squeeze the urine out, right? So it opens up the passageway, the urethra, squeezes the bladder wall so that the urine can come out and it has the passageway open for it to come out, right? So what's happening here, all right, is that I'm going to turn that on or keep it on longer so that if I have urinary retention, I can go ahead and have that happen, which would help the urinary retention issues, okay? Does that make sense? But again, we just saw that an alpha blocker also treated urinary retention, but it's treating it in a different way. Does that make sense? Because again, the cholinergic drugs are going to look like the adrenergic blockers because they're opposites. Remember when we talked about that? So you're going to see similar things being treated. Okay. So that's what's happening here. Okay. The next one is going to be called, I don't even know how you say this. Sorry, I'm really bad at pronouncing these drugs. Cevimeline, something like that. But this one is used to treat dry mouth. Okay. Because this is going to stimulate the part of the parasympathetic nervous system that increases the saliva. Okay, because we're starting rest and digest during this period. So we're starting digestion, right? We're saying it's okay to start eating. So your saliva is going to come back, right? So this kind of turns on that part of the parasympathetic nervous system that says make saliva. Okay, and it's going to say make more saliva, okay, to help treat dry mouth. Okay. So that's going to be this word, no, depending on how you want to pronounce it. Okay, this is your succinylcholine, or we call it Sux. They do use this to sedate patients, all right, especially like in trauma situations, if they're trying to put in an ET tube for a, a ventilated patient, an artificial airway, things like that. But what this one is going to do is it's going to kind of rest everything, slow everything down, and cause an anesthetic type reaction. Okay. So this one right here, that is going to be so we're gonna, this one's a little bit different. I have it listed differently here, but if I'm going to take Aricept or rivastigmine or something like that, we have two different uses for that here. We want to prevent the breakdown of acetylcholine, okay? Because acetylcholine is going to help with some mentation factors, help my body work better, all right? And when you have Alzheimer's disease, you're going to have a rapid breakdown of acetylcholine. So think drugs like Aricept or dinazepril, or donepezil, however you say it, will make it harder, or it's going to be a treatment for Alzheimer's, right? Because again, Alzheimer's causes breakdown of acetylcholine. So if I kind of stop that or promote the more effective usage of acetylcholine, it may help the Alzheimer's symptoms. Okay. And then with the stigmine drugs, the pyridostigmine and the neostigmine, these are used for myasthenia gravis. All right. Because with myasthenia gravis, again, you don't have the best usage of your acetylcholine. So this is going to help increase those effects, therefore minimizing the effects of your myasthenia gravis. Okay. So these are two more progressive neurodegenerative diseases. But again, promoting the usage of acetylcholine is actually going to be beneficial for Alzheimer's and myasthenia gravis. Okay. All right. My cardiovascular thing here is going to be that I want to promote vasodilation. Okay. So the parasympathetic nervous system, right, it's going to cause vasodilation so that, the blood pressure can be dropped down after it's just elevated from vasoconstriction from the sympathetic nervous system. Okay. So, parasympathetic nervous system does cause vasodilation. So again, we can use that to treat like hypertension and things like that, just kind of like we saw with the alpha blockers. Okay. Drugs like that on this side with the cholinergic are usually going to be like methacholine. It's not super common. Usually we use alpha blockers. Okay. Questions about that? Or anything so far?
Go over that one more time.
The methacholine.
Yes. So the parasympathetic nervous system causes vasodilation, right? So we're just enhancing the parasympathetic's ability to do that. We're turning that on more so that we can open up those blood vessels, drop that blood pressure. Okay, so this would be a hypertension medication. Okay. Make sense? Okay. This one right here isn't really used. This again is methacholine, so it can be used for either one. I do have to list it just because it is used. However, it's going to cause bronchoconstriction, okay? Because when I was in fight or flight, let's say I had bronchodilation, right? Because it opened up those airways nice and big, all right? And then let the air in as I was running or fighting someone, right? So on the other end for the parasympathetic with my rest and digest, it has to take the airway back down, right? So it was bronchodilated, so now it needs to go into bronchoconstriction. And right, we use this every day when I take deep breaths, right? I kind of stimulate the sympathetic, open up that airway, and when I go back and put it back to normal, right, I gotta activate the parasympathetic so I can put my airway back to its normal size, right? So I use this every day to regulate the size of my, bronchioles and things like that as I breathe throughout the day. So in this case, we are turning on or enhancing the parasympathetic's ability to cause bronchoconstriction. There's not a lot of reasons why I would use this or want this, because usually I want bronchodilation, right? I don't really want to close off my airway. However, it may be useful for certain asthma tests or like pulmonary function tests or something like that, where they want to induce a certain effect on your airway to cause or test something. Otherwise, they're not really going to use this. Okay. All right.
Okay, I got a question. Cardio, it promotes vasodilation, but for respiratory, it's constriction.
Correct. Because it just depends on what the parasympathetic nervous system is doing to what organ. Because we had that whole list of everything that it did, right? So not everything is going to be the same. It's not always going to dilate or constrict, right? It depends on what the organ is. Okay, so we want the blood vessels to dilate here, but we want the airway to constrict here, okay, depending on what's happening. Okay. That's why it was important to memorize that chart and why we got tested on it today, so that we could use that while we do this lecture. So like, again, I put that up in the front here, right? We had this huge list, okay, of each side. So it just depends on what aspect of this list that we're talking about, okay? Make sense? So like right now we're talking about this one, where the last one we just did talked about this. Where is it? It doesn't say on these ones aren't completely full. Again, that's why I showed you different ones. But like if you look on this one, right? Again, we're here with the constrictor bronchi, right? And then the vasodilation kind of goes with this slow the heart rate. Okay. So and then we just talked about the saliva. We talked about the constriction of the pupils, right? So we're kind of following this list. We talked about the bladder. Okay. Make sense?
Yes, but I have a question.
Yes.
This past test, I noticed that they used cholinergic and the other one a lot other than parasympathetic and
Mhm.
the sympathetic. Is that going to be going forward as well? That's how they're going to be describing things?
For this next test,
I know which system
yes.
it belongs up under.
Yeah, so it used either or because cholinergic basically means parasympathetic medication. So
Okay.
yeah, so you will see them used interchangeably.
Okay.
Okay. All right. So we just ended with this one, the respiratory effect. So again, this one is kind of just a summary slide. We're mimicking acetylcholine here, right? Because we want to enhance the effects of the parasympathetic nervous system. It just depends on what they're taking that medication and what organ or receptor they're trying to target to make a certain effect. Okay. Make sense? All right. Just like the adrenergic medications were mimicking norepinephrine and epinephrine. Okay. Because again, those were the neurotransmitters that made the sympathetic system work. The acetylcholine is the neurotransmitter that makes the cholinergic system work. So we're going to, try to mimic those for adrenergic and cholinergic. Okay. Does that make sense? Right? Because we're trying to enhance it. We're going to use more of the neurotransmitter that makes it work, right? Okay. All right. So for my contraindications, all right. Allergy is always a contraindication, so I'll never test you on that. It should just be a given. Okay. If you're allergic to something, you shouldn't take it. Okay. GI obstruction is going to be a contraindication. Okay. Bradycardia or hypotension. That hyperthyroidism, epilepsy, COPD, and Parkinson's disease. Okay, so if you have any of these issues, it is not safe or it is an at increased risk to take a cholinergic medication. All right. The GI tract is going to be one because if you have a GI obstruction, I don't want anything really going forward in my GI tract, and rest and digest can initiate the digestive tract. Okay. Rest and digest or the parasympathetic can also cause bradycardia and hypotension. So again, if I have those issues, I don't want to exacerbate them. Okay. Same with COPD, right? If it's going to cause bronchoconstriction, that would make my COPD worse. Okay. Make sense? All right. The interactions here is if I take an anticholinergic, which is the opposite of this one, right? They're going to block the muscarinic and the nicotinic receptors so that I can't do certain aspects of the parasympathetic. I'm going to turn certain things off, just like we saw with the alpha and beta blockers, but only for this part. All right, so if I take one of those, if I take an antihistamine, or if I take an adrenergic drug, which is what the very first chapter that we did, if I take any of those with the cholinergic medication, it's going to decrease the effectiveness of the cholinergic medication. Okay. So if I take any of these cholinergic drugs that we just listed with any of these, so the thing that blocks the cholinergic system, an antihistamine or an adrenergic drug, it is going to decrease the effectiveness of any of those cholinergic drugs that we just talked about. Okay. My adverse effects, I'm going to see bradycardia and tachycardia. It can do either or. You may see fluctuations, same with the blood pressure, but if it's gonna favor one, you're gonna see more bradycardia over tachycardia, and you're gonna see more hypotension over hyper, okay? Again, which is why you may see the syncope, okay, or the fainting because of extreme hypotension. And then you may see some like dysrhythmia issues, usually with the heart rate being too slow, okay? Basically, with the CNS system, kind of similar headache, dizziness, seizures, or ataxia, which means loss of coordination. Okay. The GI, you're going to see more GI symptoms here because again, it's rest and digest. Okay, so the digest part. You're going to see abdominal cramps, increased secretions, because again, it causes this, right? We literally had a medication that increased saliva, nausea, vomiting, and diarrhea. Okay. And then with my respiratory tract, it's going to increase bronchial secretions, and it's going to increase the risk for bronchospasms because we had that bronchoconstriction. Okay. I can also get toxicity of any of these medications. However, if I get too much cholinergic medication, it's going to be the most dangerous out of all 4 of these chapters. Because what's going to happen is that you're going to get all of this, but way more extreme. Okay, we're going to have too much acetylcholine. All right, we're going to stimulate our muscarinic and nicotinic receptors way too much. Okay, and we're going to see the symptoms associated with that. So when this happens early on, like let's say I take too much of one of these medications, I'm going to see the acronym SLUDGE. Okay. So that's going to cause that's an acronym, right? So it's going to cause increased salivation, increased crying or lacrimation, so tears, increased urinary incontinence, okay, increased diarrhea, increased GI cramps, and increased vomiting. Okay. If we're at this stage and you're seeing these symptoms, because this is early on of the toxicity, you're going to treat this with atropine. Okay. If it gets worse, like if we're in the later stages of cholinergic toxicity, you're going to see circulatory collapse. So there's going to be low perfusion. You're going to see hypotension. So the blood pressure is going to go way down. You're going to see bloody diarrhea. So you're going to almost be hemorrhaging. You're going to see shock, probably more hypovolemic shock, and then you're going to see cardiac arrest. So your lungs and heart are going to start to shut down. Okay. And that treatment for that is epinephrine. Okay. Because epinephrine is an adrenergic drug, which is the opposite of a cholinergic. Okay. So it's going to be like an antidote. All right. Make sense? Okay. So you have early stage of cholinergic toxicity and you have late stage. Okay. Medication treatment for early stage is atropine. Medication treatment for late issues is going to be epinephrine. Okay. We're going to skip this. So I know I will not test you on this. And just read through these. But basically, can you go back? I go back to what?
You said which stage was the treatment atropine?
You need to take atropine if you're in early stage cholinergic toxicity.
Okay.
Okay. So just read through these. I'm sorry. Was there another question? No? Okay. Just for time's sake, just read through these. They're pretty self-explanatory, okay? Because we have 40 minutes and I want to make sure, or sorry, 20 minutes, and I want to make sure we do the last chapter, okay? So I'm going to go ahead and switch to the last chapter, okay? Let me get to that. Where is it? I want to share my screen, chapter 21. Okay, everybody sees my chapter 21. All right. Any questions about anything so far? Okay. So these medications are cholinergic blockers. All right, so they are literally going to block the acetylcholine from landing on the muscarinic and the nicotinic receptors. Okay, because again, the acetylcholine makes the parasympathetic nervous system work, right? That's what helps send the messages through the nervous system. All right, so if I have the acetylcholine sending the message, but the message can't actually land on these receptors and tell the organs what to do, then the organs aren't going to do that particular thing from the parasympathetic nervous system. Okay, so that's why it's a blocker. So it's actually sitting in front of, being a physical barrier to the muscarinic and the nicotinic receptors. So the parasympathetic can't say, hey, do this. Okay. So we don't call them cholinergic blockers, though we call them anticholinergics. That is the term that you're going to see the most, so that is what we're going to refer them as. Okay. So we're going to go through these. I have these written a little bit differently. But basically, the first thing that we can use to treat this is going to be Parkinson's disease. All right. Blocking the parasympathetic nervous system, or basically decreasing my acetylcholine, is going to help with the symptoms of Parkinson's, reducing muscle rigidity and muscle tremors. Okay. Let me see here. Otherwise, with the CNS, if I give too much, I need to be careful, because too much of an anticholinergic can cause severe sedation, disorientation, or hallucinations. Okay. Which again is not what I want. That'll put my patient into a severe mental state. So I need to watch how much I give of this. Okay. So after the that we have the heart's effect here. So what's going to happen is I want to block the parasympathetic nervous system's ability to cause vasodilation or to cause bradycardia. Okay. So I want to, at a low dose, it will slow down the heart rate. Okay. However, at a high dose, it will increase the heart rate. Okay. So at a low dose, you're still going to get that bradycardia that we'll see with the parasympathetic nervous system. You'll actually see the blocking happen once we get higher doses. Okay. And then we'll start to increase the heart rate. Okay. So really, you're only going to get this effect at the cardiac system is if I give you a higher dose, okay, for the cardiac functioning here, okay. For the respiratory tract, it's going to stop the parasympathetic nervous system from causing constriction.
Okay. So at the low dose, you're not getting bradycardia?
At the low dose, you are getting bradycardia, which is what's going to happen from the parasympathetic nervous system anyways. But with these medications, we want to stop. I'm sorry?
That was on your, I was listening.
Okay. Okay. But yes, if I do give low doses, it will cause bradycardia, which I don't want, because that's what I'm trying to avoid, because that's what happens with the cholinergic, right? I want to block that from happening. I want to cause tachycardia, or raise the heart rate because it's low. So I have to give you a higher dose of an anticholinergic in order to reach that desired effect. Okay. And this is going to be like your atropine. Okay.
Okay.
And then back to the respiratory. Again, the parasympathetic nervous system causes bronchoconstriction. If I have respiratory disorders, that is not ideal, right? No one ever wants bronchoconstriction. Okay, so I want to stop or turn off the parasympathetic system's ability to cause bronchoconstriction, right? So if I put this medication right on those receptors on the lungs, I can literally prevent the message from coming to the lungs saying constrict. So that way it'll help keep them open, okay? Which is good if I have asthma, COPD, anything like that. The next one is if I have GI issues, all right, when I have the cholinergic effect or my parasympathetic nervous system, this is going to increase my digestion. It's going to increase my peristalsis because it's rest and digest, right? I'm trying to stimulate my digestive tract, right? So if I want to stop that, I am going to slow down my peristalsis. I'm going to slow down my respiratory secretions. Okay. I'm going to relax the smooth muscles in my GI tract. All right. So this is going to be more your bentyl, and I'm going to give you the names in a second of the drugs. But if I have irritable bowel disease, other kinds of diseases like Crohn's disease, ulcerative colitis, things like that, gastroenteritis, whatever it may be. If I'm having really bad cramping or I'm having like severe diarrhea, something like that, slowing this down would help decrease the, diarrhea or the cramping that's produced, okay? The next one is going to be incontinence, okay? So just like we saw with the adrenergic, okay, in the very beginning, because the sympathetic nervous system constricted that internal sphincter, right? Here, it's going to stop the parasympathetic from being able to open that internal sphincter. Okay, because that's what the parasympathetic nervous system does to the urinary tract, right? It opens up that urinary sphincter so that we can let the urine out, right? So it's literally going to tell the bladder not to do that, which is going to stop as much urine from leaking out, right? Because it's not going to be open as much, okay? So that's another way that we can use these medications to treat overactive bladder or incontinence, okay? All right. Any questions here? Okay. So the mechanism of action here we just kind of talked about. It is literally putting a physical blockage in front of the muscarinic or the nicotinic receptors, making so acetylcholine can't help the parasympathetic nervous system send the message to those receptors, telling the organs to do something that would be in the parasympathetic nervous system. So we're turning things off or making it hard for the parasympathetic nervous system to initiate certain things, okay? So that would be the mechanism of action here. My contraindications as a whole for all of the anticholinergic drugs would be always an allergy. It's going to be glaucoma. Okay. It's going to be acute asthma or other respiratory distress diseases like COPD. All right. It's going to be myasthenia gravis. It's going to be cardiovascular instability, like if you have an MI, heart failure. Okay. Anything that's going to make my heart not work as well. Or any type of GI obstruction or any kind of urinary tract obstruction, okay? Those are going to be my reasons not to take these anticholinergics or to be very cautious when I give them, okay? With my interactions, if I take any anticholinergic drug with digoxin, I have a risk of causing digoxin toxicity. And if you remember from last semester, the biggest risk with digoxin toxicity was that it can cause a dysrhythmia, and a dysrhythmia can be deadly. Okay. My adverse effects are my cardiovascular system. It can increase the heart rate, causing tachycardia, or causing a dysrhythmia. Okay. My CNS system, it can cause restlessness, irritability, again, those disorientation, confusion, hallucinations, or delirium. We saw this again back up on this slide right here, where I said that if you give too much, it will cause these dangerous CNS effects, right? Which again is going to be an adverse effect. Okay. We don't want to put our patient into almost like a schizophrenic state, okay? My eyes, it's going to cause dilated pupils. It's going to have the risk of actually increasing the intraocular pressure, which is why glaucoma is a contraindication, right? Because it could make the glaucoma worse, okay? And then with my GI tract, it's going to decrease salivation. Okay, so it does run the risk of making me dry. Okay, so it's going to dry you out. It's going to decrease my gastric secretions. All right, it's going to decrease peristalsis, which again is what we want in some cases, but it could slow it down too much, causing constipation or a bowel obstruction. Okay. It can cause urinary retention or BPH. Again, we want to help urinary incontinence, but we can go too far in the opposite direction and make it worse, okay? It's going to decrease sweating because, again, it's going to dry you out. And then for my respiratory tract, it's going to decrease respiratory secretions, which again isn't always a bad thing, but certain things could be in those respiratory secretions that could protect us. All right, so that one is a little weird, but it could hurt us if there's good things in those respiratory secretions. Okay, questions here? So here are the names. I know I listed them differently this time, but we have atropine, which is going to be my cardiac one. So if we go back, my atropine was going to be this one right here with my cardiac conduction system. If I give a high dose, it's going to increase my heart rate. Okay. Atropine is the drug that we use to increase my heart rate. Okay. Again, dicyclamine or Bentyl was going to be the one right here with the irritable bowel disease. Again, that was going to help decrease peristalsis and relax the smooth muscles, making me have less GI cramping and less like diarrhea, things like that, because it's going to slow down the GI tract. Okay. And then this one right here, Rubinol. I don't know how you want to say this one. If you can pronounce that, great. I'm just going to call it Rubinol. All right, this one right here is going to block the production of secretions. So this one is actually going to dry you out. Okay. So if you need to decrease your secretions in the lungs or your mouth or anything like that, it usually helps preoperatively if you're going to be intubated, because you know sometimes when you have surgery you need to be ventilated, right? Like if you have more serious procedures like open heart surgery or something like that, it may be helpful to reduce your secretions to get the tube down easier. Okay. This one right here, oxybutynin, we've probably heard of that one. That one is going to be for my overactive bladder. So again, that would be going back to, where is it on here? Right here with the incontinence. So the oxybutynin is going to be the one that's going to do this. Okay. And also, so is the talteridine or the Detrol. And then we also have Myrbetriq here as well. I know we saw Myrbetriq as an adrenergic medication, but it is also considered an anticholinergic medication. Okay, so oxybutynin, talteridine, and Myrbetriq all treat that incontinence or that overactive bladder. Okay. We also have scopolamine, which I know that can be used for many different things. All right, but for motion sickness, to help not have so much nausea and vomiting. Okay, which again, you may see, you know, with car sickness, things like that. So again, if we're blocking the rest and digest part, especially the digest part, we may not have as much nausea and vomiting, right? Because we're not going to be stimulating the GI tract. Okay. Also, that's pretty much it for the drugs. Again, just read through these nursing implications. They're pretty straightforward. for time's sake, and basically that's it, unless anybody has any questions.
Yes.
Yes, what's your question?
So out of all these slides that we went over, what is it that you really want us to focus on? Because you just pointed out like a few things.
Anything that's on here is up for grabs on the exam.
What did you say?
I'm sorry?
I didn't hear you.
Anything that's on these 4 chapters is up for grabs on the next exam. Can you hear me? No?
Can you second guess the study guides?
I don't know. I'm gonna have to talk to Miss Neal and Miss Webster about that.
Say, Miss Morgan, we can't hear you.
You can. All right. Have a good night. Any other questions?
Miss Morgan, we can't hear you.
You can't hear me?
Yeah, we can hear you now. What did you
Okay.
say when she asked you
Okay.
about?
So I said that any of the slides in the 4 chapters are up for grabs on the next test, which is next week. And then I said I'd have to ask Miss Neal and Miss Webster about study guides. I can't make that decision.
Well, if you can't do that, can we at least like schedule a group tutor before the test? Like, because it's all over the place. We're pulling from everywhere. Like, I know you saw the test grades. Everybody didn't do good.
I did see the test grades, but that's how I test, is it can be anything. You're supposed to.
Well, could we get like some better direction? Like,
I will see what I can do. I will work on that.
I mean, because this is all over the place, and it's like everybody trying to study everything. We can't hold all of that in. Like, it's my memory is just not, on top of everything else.
No, I understand. But usually, yeah, I do require my students to know, anything from the chapters that are going to be on the exam. I'll have to look into it.
Okay, well, could you at least get back with us within the next couple of days and let us know some things, or could we do like like I said, a study group a little bit before the test, or could we do something because, like, for some type of direction?
We can do a study group, and then let me work on any other things that I can do to help.
Then it's like we sitting in this classroom, we got so many technical difficulties, like it's hard to stay focused, it's just a lot, Miss Moore.
I know this Zoom thing is not ideal.
Hello, Miss Morgan.
I'm sorry.
She got a.
Can you hear me?
She just missed us. No, I had turned it off.
You should be able to talk
Oh,
to
we
me.
get to the line.
All right, I will look into it. But right now, that's all I can say. Okay.
What she say? Permission from Miss Neal? She said, Miss Neal said, well, what did she say? I don't got nothing to do with it. And we said.
I'm just gonna ask Miss Neal because she emailed her and say it's okay. Well, if Miss Neal can email her back, then that could get something going because this is ridiculous.
All right, I will see you later. I will work on how I can help you. Okay.